Good. Do I?
And you go right ahead. We kind of went over some introductory types of
All right.
things, so we're just ready for you to start.
Thank you. I appreciate it. I'm also in a horrific thunderstorm, which has not damaged electricity yet, but if anything else could go wrong this morning, that may be the next slight interruption. So if it happens, I'll crawl back in. I am very glad to be on with you today because I'm going to do a combination of things that are hitting a number of critical access swing bed programs across the country in different states, different amounts, but it's becoming more routine. So when you get a chance to look at the newsletter, there are some things in there that start with, and I heard Becky point out the involuntary discharge, and that's explained. And the story behind that is, even though I've been saying that we've been getting state surveys for critical access swing beds for maybe a little over a year now in different states, it hadn't been routine yet, but I had been in a facility about 6 weeks ago teaching on one day, and the next day the state was in there. So it's the first one in the state of Georgia that had been surveyed. And what was interesting is the first thing they asked for was the involuntary discharge, which is why I've put that at the top of the newsletter that you're going to be able to see either in your mail today or at least later today. Let me just explain the importance of it. An involuntary is a list of things that I have put in there, so you don't have to memorize anything, but it's anything from the fact that they don't need to be in the skill level anymore, or more importantly, it's used a lot of times in nursing homes because a resident is either unsafe for themselves or becomes a danger to somebody else in the nursing home. So an involuntary discharge means we're sending them to a psych unit or whatever else might be going on. About a year ago, and the skilled nursing facilities really are just getting into this. That's why I was surprised this was the first thing they asked in a critical access swing bed. You are to contact the ombudsman and let them know specifically about any involuntary discharge. And the reason is that the ombudsman then becomes the patient advocate. So if something's going on where this doesn't happen in swing beds often, but we're seeing so much more dementia with behaviors, I think it could, where maybe a patient takes a swing at a staff member or a swing at another patient if they're in a group activity. And you have to make decisions then based on that, whether this is the right setting for them, whether you need to transfer them out. Then while that decision making is going on, you are to contact the ombudsman, so the ombudsman knows what the incident has been that is causing you to consider it. And then at that point, the ombudsman becomes the patient advocate to make sure that all the sides of the equation are being considered. So that makes sense. Originally, the rule said that you were supposed to contact the ombudsman every time somebody was discharged, and that just absolutely caused panic. There are only 16,000 nursing homes in this country, and you can imagine how many discharges come and go from that. And so they couldn't come up with a standard sort of statement. So you are to contact your own ombudsman. And I don't know specifically about the state of Indiana. There's usually I know many states have somebody for the southern part of the state and somebody for the northern part. You may be split differently, or you may only have one ombudsman for the entire state. But normally what has happened is they've wanted a log sent into them at the end of the month listing your discharges and where they went. So John, and I included an example of the involuntary, but not the voluntary, because it's pretty straightforward. So John Smith is discharged on 6/12, and he's discharged to home. And that's all you have to put. Or he's discharged to home health, or he's discharged to another facility, like he had to go back to the hospital. That's a bad example. He went to another nursing home as a peer-to-peer movement. So that list, your ombudsman may tell you that's what they want, and they only want it sent to them once a month. But every ombudsman in the country is making a different statement. That's why it's really important you contact yours. As far as the involuntary discharge, I included a kind of 2-line sample of things that you should put. And again, your ombudsman needs to be contacted immediately. So that is the lead-in today to say that came from a survey of a critical access swing bed as to why it's heightened. And it's been heightened for about 6 months in the nursing homes across the country. So they're very serious about it from CMS. And what we're seeing going along with that is additional information and or the need for survey teams to be reviewing quality. Quality these days in skilled nursing, as you know, is tied directly to person-centered. So if you hear this ombudsman being involved, that's sort of tying this into, to the point that we have a requirement in skilled, and which includes you, that we must have a person-centered or a care plan, baseline care plan in place within 48 hours of admission to your program. And that baseline care plan, sort of like we've always done an admission care plan that just covers things like, well, if they're a diabetic, what is their diet, or if they're on certain meds. We've always done something like that quickly before we've done the comprehensive care plan. But in this case, they want the patient involved in it. They want to know that you have put down his or her goals while they're in your skilled bed and after discharge. So it's somebody that has had trouble with surgery and they want to be able to go home and go back and garden. Again, that's their goal, and that helps set up activities, that helps set up your documentation, certainly that should help set up any therapy being provided. And the rule is before discharge, the patient or the patient representative must sign off on that baseline care plan that it did indeed reflect his or her goals. So you hear person-centered. The other wording that I didn't put in the newsletter that you're going to hear a lot of between now and October 1 is for PPS settings. So that's for all the nursing homes in the country, and it's for the PPS swing beds. It is not literally for the critical access swing beds. So this is not a change for you, though we're going to talk over the next couple months. We're certainly going to talk when we have the face-to-face meeting about Medicare intent and what they mean behind it. And it is called PDPM, if you've heard those initials. And the PD stands for patient-driven. So you hear person-centered and patient-driven now tied specifically to the clinical and tied specifically to the payment for PPS. That, again, is telling us that everything is coming into, are we making gains when we have somebody? In other words, are they improving in their therapy? Are we getting them where, if we have to help them manage pain, that we have a pain management plan that can go home with them for them to follow? You know, if they're a newly diagnosed diabetic, have we clearly provided the education and training that them and perhaps a family member needs to support to them? And so this leads all back to documentation, and that's up and beyond what's in the newsletter. That's the one thing that I want that you see on the screen today that I really want to go through. And what I'd like to suggest is I believe that we all should be doing self-auditing. And the best way to do a self-audit is pull it up on a screen with your team in the room and start going through different sections. This means nobody can take anything personally, but you can tell from electronic medical records, often you will see the same sentence or sentences repeated over and over and over in a 12-hour shift or even over a 24-hour period. That's not individualized. That's not person-centered. You can be checking to see if therapy notes, nursing notes, activities, social services, anybody's professional notes are saying this patient really wants to go home to whatever the answer might be. There should be some kind of notice like that on a daily basis. And what you also now are trying to do is get yourself in check, audit yourself for the patterns we fall into using the same language. The list you see here that I'm going to go through, and a lot of this was geared towards therapy, but this is coming from the MACs, and the MACs are your payment group or your fiscal intermediary if you're not on that part of the side of the business. And these are words and phrases that they have now listed publicly that if they see them, that's a red flag for them. So this is a good list for you to run through and see if your documentation shows this. So no change in status is really bad for anything in skilled because we are supposed to be making progress or discharging. Words like ongoing, continues to be, or will continue to do, same as, remains, little change, normal. I'm still trying to decide what normal means for a human being, so that's a word that we shouldn't be using at all. Voice no complaints. If that's one time, like after you've been trying to do pain management with a patient and you say they're not voicing any complaints now, that would be valid because you are evaluating what the pain management plan is or is not doing. But to continually see that, my favorite nursing homes is always voice no complaints, call light within reach, sleeping comfortably. The common phrases that we've used for years and years and years in the industry, they don't want to see anymore. Appears, seems would be the other one, seems like or appears. They don't want to see that. Test results doesn't define what the test was or how it's related to what you are documenting. Essentially unchanged, status quo, fair or poor rehab potential. If you are working on a patient for their therapy and we are writing that they don't have any rehab potential, then Medicare is going to say, why are we paying for this skilled visit, basically. Maintaining, status unchanged, approaching a maintenance level. There are some rules about maintenance level. You probably will not get into a maintenance level in a swing bed. That's more for long-term care where we're evolving a patient into making sure they can go home maintaining whatever level of function therapy has gotten them to, and or they're becoming long-term care residents. Patient refuses treatment every day. I would tell you, we used to have a rule, if any of you have been around a long time, that was called 3 strikes and you're out. If they refuse therapy 3 times, we discharge them from therapy. We don't have that time anymore. We basically have 24, maybe 36 hours to get them to participate and the reason that you may not notice this, but the PPS ones notice it, is they must have therapy 5 out of 7 days for a therapy to be a primary payer source for PPS. So again, following Medicare intent, they're saying, look, if people can't tolerate, aren't doing it by choice, aren't making progress, refusing treatment, then they shouldn't be a primary therapy patient, even in your critical access swing bed. You're following, again, that Medicare intent. Not motivated or low motivation. We're trying to get them home to not be perfectly fixed, but to go home either by themselves to home health, maybe come to your outpatient therapy, but we're part of the process where they're evolving into getting them back to normal or as near to the normal that they had prior to whatever event put them in the hospital and your swing bed. And then anything that says non-compliant, that's almost an automatic stop. So this list here, I can explain all of it, but what's interesting is this is what the MACs have put out that said immediately if they see any of this, it will be a red flag. So if you are sending in claims and they do chart reviews with them and they see any of this, they're going to come back and say, why did we pay for this, basically. So again, I think the important thing that you need to do today is set up a self-audit. And the best way to do it, again, is get yourself at a conference table, pull it up on screen, because so much of what we have is electronic now, and go through the notes and just look at 12 hours, 24 hours on a single patient of the nursing notes, of the therapy notes. Look at the supporting notes. Did activities write anything? Is there a social services notes? Do you have the physician documentation that you need to support ICD-10s as to why they're in your program? Dietary notes are becoming increasingly important. In fact, last October, a dietitian was added as a mandated member of the interdisciplinary team for all skilled nursing. So we should see something that shows, paints a picture again. We've heard that for a decade, but at least paints a picture of how this patient is doing in your program and that your documentation shows that. This list I've sent on to Becky, and she can forward it to you today after the webinar. Yeah, I just got a massive flash of lightning if you heard that slight pause. And then if you'll go through it and look at it and then look at the newsletter, please feel free always to get back with Becky. She forwards the questions to me. And Becky, with that, I think that's the main thing that we need to get through today, is that the audits are picking up and the surveys are picking up, and we need to do our own self-auditing to see how we would appear to an outsider. And I did hear you long enough to hear there were a couple of questions that you wanted to try and answer before we get off the phone.
Yes, if we could. And please feel free to chat in any questions as we're discussing these topics here, so that we can all hear the information that Kerry provides. One question that was chatted in is every 24-hour antibiotics without therapy enough for skilled care?
The general answer would be no. The question is, what is the antibiotic for? So if somebody has let's say they have COPD or CHF, and they're taking an antibiotic because of, I don't know, a respiratory issue of some kind, lung issue of some kind. You could tie it back to their chronic issues, and then that would be a medically complex type of patient. Usually the antibiotic is, well, I'm not going to say usually. A lot of times in the age group that we have admitted to swing programs, those patients, those antibiotics are tied because they have underpinning medical conditions that are chronic. And so it would be an event where you're trying to do the antibiotic. Maybe it's IV that is needed, and that certainly helps define it. The second part of that is, I'm going to say this very carefully, but I don't think there are many patients that are elderly, and I'm not talking about your 65-year-olds that maybe had a joint replacement that are pretty active people. I'm sort of raising that age, the elderly, to 72, 75, but either way, it's people that are not active, and you know what I'm talking about. You're talking about people that are motivated to get home because they want to go hiking again, or they want to go, riding their bicycle or whatever they do, versus the people that are really, really impaired now, and it's hard for them to get out of a chair, and their balance is not good. But regardless, because of the hospital stay, I find there's very few times they don't need a little bit of therapy to get them back to the baseline. The anecdotal information is for every day in the hospital. An elderly person loses 3 days of function. So if you're keeping somebody short time to finish up an antibiotic, I think you could also justify some short-time therapy. If you're keeping them for IV antibiotic because it's a 30-day antibiotic and you don't have a home infusion or home health company that will do it, then we've got a different kind of issue that you're going to have to document, that there's absolutely no other way for them to get that 30-day antibiotic unless they're in your swing bed program. So that's a different type of documentation. So no straight answer, but I think there's 4 or 5 variations in there that I gave you that if you use and can legally use several of those, that would help support why you're keeping them for an antibiotic.
Great, thank you so much. The next question was around the survey tags for a swing bed unit. Are there any comparison, or are they the same kind of tags the long-term care facility receives?
Yes. So I am not sure legally what tags are going to use for critical access. Remember, this is just starting. I'm watching the one in Georgia because it's a client of mine. So they've sent in their response to the state. I want to see what tags they come back with to see if they're going to use the F tags. The F stands for federal tags. If you've been around skilled nursing facilities, you know that they have been surveyed for umpteen thousand years, and the F tag is the what they get cited on and can be penalized financially on those F tags. It wouldn't hurt you to download the F tag list, and you can get that from CMS. In fact, I'll write myself a note, Becky, and I'll send you an F tag list. What I don't want you to do is feel like that's literally everything you could be tagged on, because it's very specifically written to 2 things. One, to the PPS rules, which you know you're not under right now. So that means there's a lot of tags that are because of the rugs, which you don't go under that payment system. And also because we're not sure from the last things that have come from CMS, they are saying more that you are following under a different set of rules because you are under the critical access hospital bundled rules. But we haven't seen how that translates into paying attention to, the F tags specifically. Looking at them generally, you will get an idea. But let me give you some general ones that we should just be doing because we're taking care of patients. So when you look at the quality measures that all the PPS ones are under, and there's like 7 different quality things. There's QMs, there's QRPs, there's things called value-based purchasing. All of these have measures under them. You know they have the 5-star rating. You know you can go out and look at any nursing home in your area on Nursing Home Compare, and their last survey and their 5-star and their staffing levels will all be posted. You're not under any of those rules yet, and I don't see it coming in the immediate future because PDPM is taking up so much energy for CMS. But look at what they get cited on. Those are the things that we should be avoiding for any patient, and certainly for any skilled patient. So that includes is a patient reporting pain? What are we doing about pain management? And again, we've got patients that say they have a level 9 and they're playing cards. And we have people that say they have a pain level of 2 and they're ashen. So we again have to have the right documentation to support what we're doing. They're looking at pressure ulcers. They're looking at anybody that's being that is on an anti-psych med, but particularly that's newly receiving an anti-psych. So what would you do there? You want to have the documentation from the hospital stay or from an H&P as far as the ICD-10s that would support why somebody might be on an anti-psych med. You want to be putting that in your documentation. The key issue going forward for therapy and nursing, but certainly tied to the PDPM, is have they made improvement in function? And there's two levers there, and it's sort of an old-fashioned, part of it's PT and part of it's OT, but they come in functioning a certain level because they are impaired because whatever illness or injury has put them in a hospital, and their function has declined because they've been in a hospital bed. So they're looking for notes that talk about how their function has increased and improved enough so they can go home safely. And if I think I've said this to you, but the only reason we have a skill level of care, only two reasons, is for quality of life, which are the ADLs, and for safety. And as you probably know from the return to hospital readmissions that are going on with the PPS hospitals, much of what's happening is they have falls at home immediately after leaving the hospital, and even sometimes after leaving skill programs. So you certainly want to look at that. And then I think you're going to be looking at prior hospitalizations and what they've been in. But if you take that short list that I just sort of ran through, and I think I can do this off the top of my head, but you're looking at pain, pressure ulcers, falls, use of anti-psych medicines, and improvement in function. If you take that short list, many of the quality measures and many of the tags that would come from a survey team will center around those areas specifically. The other things just go to standard care. Did we pull a curtain? Did we wash our hands? And you'd be surprised how often we get cited in nursing homes because somebody didn't wash their hands the right way or they didn't pull the curtain the full time. So it's things that we all should know, and maybe it's time to do a refresher course for your whole team to say, we get going from room to room or from person to person or whatever's going on, and we need to go back and remember the basics that we all are very, very aware of in healthcare, but we just sometimes let slip. And there's a Murphy's Law. If you're not going to pull a curtain, I guarantee it's the day the state survey team is in the building. So use those kind of common things that skilled nursing is getting cited on, and double check yourself so you can defend yourself if the survey team walks in. Does that help?
Yes, I think that should answer some questions and provide some guidance there. I will interject that Andrea did share that they did have an insurance company that denied skills for every 24-hour IV antibiotic. So, yeah, Andrea, if there are additional questions based on Kerry's response, please let us know. But I think you provided some good guidance there.
Yeah, can I break in there? Insurance companies are denying a lot right now. And basically when we're talking about survey and stuff, we're obviously talking about Medicare A coverage. Insurance, we seem to be fighting a lot of things that I think should be more straightforward than they do. So I would go back and again, those kind of hints I gave you on documentation and see if any of that's there. And then I'm sure your hospitals are quite wise in the fact that they need to fight all the insurance appeal. Anything through the insurance, a lot of that insurance can be overturned as it goes through the appeal process, which is obviously time consuming and costly to the hospital, but we seem to be winning a fair amount of the skilled ones if we appeal them.
Great, thank you. Then the last question that we had was around the bed alarms, and is that considered a restrain and swing bed? So I thought it would be good to share with the whole group because I bet that question has come up in other facilities.
Yeah, so here's where I'm caught in the middle. So therefore, you're caught in the middle with me because you're critical access and because we don't have the whole manuals written out for you that we have. Though I'm working on a manual now, and I hope to goodness we have it generally put out in the next couple months. They're not very clear, but let me tell you what the nursing homes are all under and the PPS swing beds. We are to use no alarms anymore. None. Bed alarms, chair alarms. We can't even use something for a wanderer in a nursing home. And right now they have chips that you can put in the sole of a shoe. And so therefore the patient has no identification that he or she is a wanderer to the public, to himself, to his family. And the federal government will not allow us to use that. So many nursing homes have now had to put up cameras at all the doors, exits to outside, so that they can watch wanderers that way, because we're not allowed to put any kind of alarm on them anymore. Now that one I think is to the point of being ridiculous. The rest of it, I think one they considered a dignity issue. But the second thing, remember when the bed rails came up, one of the reasons the bed rail came up as a restraint were people in nursing homes climbing over the bed rails, which we were trying to keep them in the bed with the bed rails. They were climbing over the top of them and falling, and more often than not hitting their head. It was causing injuries. And that's what started this process. And it just continues I think they're saying like chair alarms or bed alarms, even if they go off, we don't have staff standing at the door that we can stop or intervene in time. So straight out, no nursing home, no PPS setting can use any bed alarm of any kind. I would suggest that any survey team, particularly state survey team coming in or federal survey team coming in, would suggest that you're in the same boat with that. Now, having said that, I've read plenty of your policies for your hospital where you have it specified when and how you're going to use different alarms for hospital patients. And I would just review that policy and see what it says, and then try and find a safe ground, and perhaps just use bed alarms when you absolutely have to, for whatever reasons you can document. But you want to make sure whatever you're doing ties into your policy, because that'll be the first thing they'll look is, are you following your own policy? So I'm afraid I can't say absolutely not for you because we don't have that in writing, but I would bet 95% that they're going to say they don't want alarms on skilled patients.
Okay, great. Well, thank you so much, Kerry. This has been good information today, as always. And we will send out the recording to today's session once we are able to receive it from Zoom. And I will also include the document that Kerry is showing on the screen, a list of words to the wise, skilled nursing coverage documentation. And if you have additional questions, let us know, and we will get those answers back to you. So thank you so much. I hope you found the information today helpful. Have a great day, everybody. Thanks, Kerry.